Good morning, everyone. My name is Christelle Solomon. I am a sickle cell warrior, a transplant recipient, and I am the health policy and education analyst at the UCSF Sickle Cell Center of Excellence. And I'm so excited to have this town hall today to just be a part of hosting this. I am passionate about all things cell and gene therapy, all things educating warriors and advocates and even providers, just so that we can be on the same page. And our goal is always to bridge the gap between all the parties that need to be at the table when it comes to really prioritizing the health of sickle cell warriors. And so, with that, we are hosting our gene therapy updates town hall. And we know there's so much evolving in the space of cell and gene therapy when it comes to sickle cell. And sometimes it feels like things are happening at the speed of light and also at the speed of molasses all at the same time. And so we really wanted to have this event today to really be able to give an overview on gene therapy, really give information that will allow people to feel informed, to make well-informed decisions about their health, whether or not they want to participate in something like gene therapy, and to also talk about some of the things that have changed in the landscape. There are multiple gene therapy options now. We're in a new era where we have the option to choose, and sometimes that means options that were available in one season are now FDA approved, or options that were available in clinical trials are no longer an option. And so I think it's really important for us to all be connected and up to date with how things are changing. And that's the goal we have for today's event. I'm so happy to see the chat active with warriors and people from all over the world. Advocates, love to see it. So please continue to engage in the chat. I'm going to go ahead and introduce. We have our experts today, Dr. Mark Walters and Marcy Moriarty. And man, I obviously am biased because I've been blessed to receive care from these two individuals. And while I could give a very formal introduction listing all the amazing things on Dr. Walters' long resume, I'd like to just keep it simple and really highlight the things that have stuck with me as a patient. And Dr. Walters is a provider who really cares about warriors, who really cares about us and is willing to have the tough conversations, the long conversations, when it comes to really making good decisions for our health. And so I'm just really excited to have Dr. Walters share his knowledge with us because I remember asking him a lot of questions in my transplant journey. I was like, how does this work again? Are you sure this is gonna work? And just feeling really safe enough to share my concerns, but also knowing that he is an expert and he can really impart a lot of knowledge. And the things that really stuck with me about Dr. Walters is that he's also not afraid to say, I'm not sure, but let's figure it out together. And in the space where gene therapy is constantly evolving, that is an answer that is very valid. And so, without further ado, I've already talked for longer than I needed to. I'm going to introduce Dr. Walters, and Marcy will be available later in the Q&A session to answer questions. So,
Thanks, Christelle. That was just lovely. I don't deserve your accolades. But here we are. It's so great to be with you today. I'm glad to sorry. Is this better? No. How's that?
we can see your the like notes. Is there a way to show it where it's
Uh,
just, yeah, that's better.
Okay. Thanks for inviting me. It's always a a treat for me to spend time with warriors and to talk about um, these type of therapies that I have learned a lot about and that I'm so keen to get to people who have a strong interest to pursue them, understanding they're not for everybody, and in fact they might only be for some of you. But what I don't like is how difficult it has been to get the word out, to educate, and then for those who want to gain access, to ensure you have access. So I'm going to start with just just some sorry, I'm closing the poll. Um, just some basic information about sickle cell disease that you already know, which is that it is a multi-system disease and that virtually every organ in the body is affected. So when, when, for example, the spleen is clogged by blocked blood vessels, that leads to a condition in medicine we call functional asplenia that leads to a risk of certain kinds of infections. If there's blockage to blood flow in an artery in the brain, that causes a stroke. And before we started screening children who might be at risk for stroke, sickle cell disease was the leading cause of stroke in childhood. It isn't anymore. And then, of course, pain, which is the blockage of blood flow and oxygen to muscle and bones and other tissues, is the hallmark of the disorder. And the idea is that if we could intervene with a transformative therapy early in life because it was safe and effective, we might prevent these complications from occurring. So that's the reason why I've been so interested in developing these therapies. The other issue, and this is an example of a Kaplan-Meier probability curve. So this part of the graph is percentages, so going from 100% to 0%. And then this part of the graph is age in years. And it just it's very sobering information. These are two very good adult sickle cell centers at Vanderbilt and the University of North Carolina on the East Coast. And it begins at age 20, which is when they start accepting young adults in that clinic, and it just tracks their mortality. So, how many people have died with sickle cell disease based on age? And here we reach the 50th percent. So half the persons have died by age 48 if they have the hemoglobin S beta 0 or SD type of sickle cell disease. And surprisingly to me, survival in SC and S beta plus thalassemia, these two kinds of sickle cell disease, aren't much better. Average median survival age is 55. So this is a 30-year decrement compared to blacks in America who don't have sickle cell disease, and it's an acute example of a health disparity. So why is why is there this 30-year decrease in lifespan just because you have inherited this disorder? And that's the thing that we're trying to address by instituting a transformative therapy before you start down this curve. Um, the other thing, of course, that's equally important to consider is this the right treatment for me? So there are clinical benefits, which is the elimination of symptoms and signs of the disorder, and then there are risks, and those have to be carefully compared and ask the question: are these risks patients are willing to take? Has there been sickle cell disease related damage to major organ systems that might make the treatment more risky? And it is a grueling treatment. So, are there adequate psychosocial supports in the community and the family to support a person going through this rigorous treatment? Um, and then on the benefits side, who's most likely to benefit from a transplant? Um, a question I hear a lot is, this seems really difficult and not entirely safe. Should I wait for a newer, better therapy? Um, and then should I do a transplant? Should I do a transformative treatment before or after complications arise? Should I wait to know that that I have a severe form of the disease, or should I go for it before I've had injury to my organs that might make my life more difficult? Um, and then here are some quotes from persons who have been considering the treatment. So some have used terms such as, I would never allow it to happen, very leery of a bone marrow transplant. I wouldn't consider an option for me. I don't want no bone marrow transplant because you could die from it. Um, one participant expressed, you don't want to get rid of sickle cell and end up with something worse, which is very true. One patient said, even if it's about the transplant, even if the transplant is life-threatening, I'd still do it. Living with sickle cell eventually is life-threatening. And then one parent said about her son, he's kind of sick of the pain without knowing that it's going to be 100% successful, then I would only choose it if I had to, but that's if the other options failed. He was very, very sick, and blood transfusions were just starting to take over his whole life. So these are the things that go through a person's mind and that we need to listen to in the journey to making a decision about whether or not to pursue this. Um, the gold standard is what we call an allogeneic bone marrow transplant using a brother or sister who's a perfect transplant match as the donor and replacing the sickle producing blood cells in the body with those from the healthy donor that doesn't have sickle cell disease. But unfortunately, that's a barrier because only about 18% of families will have this well-matched sibling donor. And then if we looked outside the family, we could only another 19% of the time find a suitable, well-matched, unrelated donor. So even if I wanted to treat everyone with an allogeneic bone marrow transplant who I see, I could only do it about a third of the time. And then some clinicians don't refer patients because they're worried about the risks of the transplant, things like graft versus host disease or end up dying of the procedure itself. So it's really this allogeneic transplant has been largely restricted to children and applied quite sparingly, although this is starting to change. More and more adults are choosing this as an option. So the question is, what about gene therapy? Can we modify one's own blood stem cells that currently produce sickle hemoglobin? Can we modify them for a clinical benefit? And if we're able to do that, if we're able to reverse the the disease and its symptoms, can we assure there's equitable access to the treatment therapies, and not just the United States, but worldwide? And that's these two questions go hand in hand, in my opinion. So, finding new transformative therapies is where we're going. So, so I've already talked about a bone marrow transplant on the right. That's fairly straightforward. You collect the stem cells from the donor and then infuse them after giving the chemotherapy conditioning. Uh, the gene therapy or gene editing relies on a person as their own donor, and there's a procedure called apheresis where we collect some of their blood stem cells. And in gene therapy, we add a gene that either increases the fetal hemoglobin or uh, introduces a new globin that has anti-sickling activity. Or in gene editing, there are ways to edit the genome to increase fetal hemoglobin or to correct the sickle mutation directly. And in all of these, uh, the modified cells, or in this case, the donor cells, are only infused after the chemotherapy has first destroyed the sickle producing cells in the body. Now, what are these therapies for sickle cell disease? In gene modification therapy, a warrior is their own donor, which is what I just said. I'm emphasizing that. So one approach is to add an anti-sickling gene. The best tested example of this is goes under the shortened name Betacell or the trade name Lyfgenia that's made by Bluebird Bio, and it uses a virus to get the anti-sickling globin gene into the stem cells and expressed in the red cells. You can alter an existing gene to increase fetal hemoglobin that has anti-sickling effects and can eliminate the anemia. And the best tested example of this is a product called Casgevy that uses the CRISPR technology to knock out a gene that represses, that stops fetal hemoglobin from being made after a baby is born. So it reawakens the fetal hemoglobin in the red blood cells and eliminates anemia and the sickling effects that way. And finally, there's a clinical trial that we're just starting now at UCSF in Oakland and at UCLA that directly corrects the sickle mutation to stop the disorder. And we also use the CRISPR technology to make this change in the DNA sequence. So this is a schematic of how Lyfgenia adds a healthy globin gene. The person with sickle cell disease is brought to the clinic using a special IV that's inserted in a large blood vessel, usually in the neck. Um, we use this machine on the very left that can separate the blood cells according to their type, and the stem cells are collected after running the blood through this machine several times. Then the stem cells are shipped to a manufacturing site where they're incubated with this lentiviral vector. That's the piece of DNA that contains the anti-cycling gene and can inject itself into the blood stem cells. And then after that extra gene gets into the stem cells, the cells are frozen, and if they're safe and effective based on the testing, they're brought back to the transplant center where we use a chemotherapy drug called busulfan to wipe out the sickle-producing blood cells, and then we give those gene therapy modified cells in the same way as a blood transfusion. And then we wait for 1 to 2 years. We follow up for the effects and see if it was successful. Now, the way this extra uh, globin gene works is that it interferes with formation of the long sickle protein strand, something we call polymerization, and it's that long strand that gives the sickle shape its characteristic shape, and it converts this banana-shaped cell to a round, flexible cell again. So another approach, which uses the CRISPR technology, which is like using a spell checker to find almost like the needle in the haystack, a particular DNA sequence that can be changed. So it does that by these components that are introduced into the stem cell. And then there's a region in this gene that I call BCL11A. This gene is the anchor that turns off fetal hemoglobin at birth. You can inactivate this gene just in the red cell in a way that raises the fetal hemoglobin again. So this is really hard to explain, which is why I usually spend a couple of visits to get the point across. But you can imagine that there's some kind of anchor or clamp that attaches itself to the fetal hemoglobin gene that after this change in the DNA sequence, that clamp isn't made anymore. The fetal hemoglobin gene is free to be made in the red cells after this modification. Um, and honestly, both the treatments have been highly effective. So the Lyfgenia experience in 34 patients with sickle cell disease is shown on the left. The Casgevy experience in 29 patients is shown on the right. And each lane in what looks like a big swim pool with lots of lanes, we call it a swimmer plot. Each lane is one person who got the treatment. And the red dots on the left and the blue diamonds on the right are pain episodes. So in the 2 years before they got the treatment, all these patients are having lots of painful episodes, lots of hospitalizations. And then notice how the red dots on the left and the blue dots on the right largely disappear. So 28 out of 29 patients were not hospitalized for pain up to 4 years after they got the treatment, and 32 of 34 patients with Lyfgenia didn't have pain in this 12-month window where they were followed, although a few others began to have pain later. But still, it was a really a striking improvement. And almost everybody had a benefit in terms of reduction in pain. And that's really the reason why both of them were approved, because they seem to be quite effective with side effects that we seem to expect going through, a bone marrow transplant. So I get asked all the time, they're both approved, which is better? And now that FDA has approved the treatments, should I get the treatment or wait for something that's even better or safer, that's still experimental, or should I just continue the treatment that I'm receiving now? Um, and you'll see that I don't answer any of these questions because this is an individual discussion. I'm not really clear any of these is better than the other, but there may be characteristics about you personally that would make me lean towards one rather than the other. And then, waiting until something's better, should I continue the treatment I'm receiving now? That's a very personal decision that I can only help with. So why are there's such a reluctance to think about this? Well, it's a difficult treatment. The chemotherapy causes painful mouth sores that, in my experience, particularly in adults with sickle cell disease, can linger for a long time, for weeks, even after the chemotherapy has been completed. There are infections that can occur when the immune system is low, when we're waiting for the new cells to grow in and to restore the immune system. There can be damage to the liver from the chemotherapy. And while there's a drug to treat the damage, it extends the hospitalization by 3 weeks. Platelet recovery. Platelets are the type of blood cell that forms a blood clot, so you need to have that in a safe range. And until the blood system has recovered, we give platelet transfusions. That can take a long time to recover, 3 months, even up to a year. And pain continues, particularly in those who have what I call high impact chronic pain, where they have pain. If you have pain every day, if you're taking opioids every day or nearly every day, that chronic pain takes a long time to go away, up to 1 year and sometimes even longer. And so we have to set your expectations about what will happen after the treatment. It is not magical. That kind of pain doesn't go away as soon as you leave the hospital. And then what are the long-term and short-term effects of the conditioning or the chemotherapy? So in the short term, everyone loses their hair, fever, and infection are common, nausea and vomiting, of course, although we can give medicines to prevent that, lowered blood counts and need for transfusions, bleeding, fatigue, loss of appetite. In the long term, infertility, I think, is, if not the most important, one of the most important, and we need to make accommodations to address that fact. There can be clouding in the lens of the eye called cataracts that can affect vision. There can be damage to glands like the thyroid gland. Bone health is weakened and probably a risk of cancer just as a consequence of going through the treatment. Um, and just saying more about that, this has been seen in two patients who received the Life Genia product when it was still known as lentiglobin. So this is adding an extra piece of the DNA. And what we worried about was that that piece of DNA landed near a cancer-causing gene and activated it. And in the first case that developed 3 years after the treatment, no gene therapy DNA was found in the leukemia cells. So the gene therapy vector, that DNA didn't trigger the leukemia. And in another patient who also developed leukemia 5.5 years post-infusion, there was gene therapy DNA in those leukemia cells, but near a gene that does not have a role in cancer. But there was something about, to be honest, there was something about going through the treatment that triggered the cancer. And so I'm always emphasizing that this treatment is associated with the risk of leukemia, even though with improvements in how it's done and with the Casgevy product, no person has developed leukemia. I still think there is a risk. There's a question.
Let's take questions at the end. If you have your hand raised and you want to ask a question, there's a Q&A chat box just for the sake of time, but we will definitely get to your questions.
So the recovery time is 4 to 6 weeks in the hospital, and then weekly monitoring in the transplant center for 3 months. And then the long term, we'll see you every 6 months, or more often through the first year, every 6 months for 3 to 5 years. And then we're required by the FDA to see you at least once a year to monitor your progress, to see if the treatment is effective, if there are new side effects that we didn't know about for 15 years because it's such a new therapy. And it is expensive. Lyfgenia, $3.1 million per person. Casgevy, $2.2 million per person. So you can imagine that insurance companies are going to review that very carefully and could be a barrier to your access. And but some states have signed up for a new cell and gene therapy access model that's outcome-based payment, and California is one of them. So I'm hoping that the barrier, if you have public insurance like Medicaid or Medicare, will improve. And then the other thing, which I just mentioned, is that there's a black box warning for Lyfgenia being associated with a risk of leukemia. Um, so here are the gene therapies that are available in the U.S. for sickle cell disease. I've already mentioned Casgevy and Lyfgenia. They are FDA approved. There's our own clinical trial at UCSF and UCLA called CRISPR-SCD, using the CRISPR technology to correct the sickle gene. A trial like ours is called NuLaCell, which also uses CRISPR technology to correct the sickle mutation, sponsored by a company called Kamau. And then GRASP is a trial that's just finishing. It's no longer enrolling new patients that uses an RNA silencer molecule to suppress that molecule BCL11A that then enables fetal hemoglobin to be induced. Um, There's two other clinical trials, one called Beacon, that uses CRISPR technology, a modification called adenine-based editing, ABE, to increase fetal hemoglobin. There's a trial at St. Jude Children's Research Hospital that also uses CRISPR technology to increase fetal hemoglobin. And then sadly, there are three uh, products that showed quite a lot of promise, in particular Ruby, that all of these increase the fetal hemoglobin, but because of the marketplace, they decided it wasn't profitable or possible for them to make their products commercially available, and so they have dropped out. And this is a disappointing thing about the marketplace and in sickle cell disease in particular, that is something that I find very disappointing. So updates in gene therapy for sickle cell disease. Ex vivo means gene therapy that you do outside the body, and all of the treatments I've just described are ex vivo gene therapy. In vivo gene therapy means we inject those gene altering tools into the bloodstream, and so all of the action happens inside the body. And this is exciting because if it was successful, it would eliminate the need for that high dose chemotherapy that we currently have to use for the ex vivo treatments. So there are no FDA approved in vivo gene therapies, although there are some under development. Um, and I just talked about the Ruby clinical trial that had such wonderful results, but the sponsor, Editas Medicine, elected not to develop that as a commercial product. And then, of course, our clinical trial is enrolling here at UCSF in Oakland. So this is a CRISPR technology that's aimed for treating adults under an investigational protocol who are having frequent painful events. And unlike Lyfgenia and Casgevy, which either adds or modifies um, a gene other than the sickle gene, CRISPR precisely corrects the sickle mutation. So that's what this diagram is meant to show, is that if the sickle mutation is here in orange, it cuts it out and then inserts the right sequence into the same location. So, so this is primarily a study about safety, and we're asking, after you change the DNA this way, do those blood stem cells work properly? And or does it uh, lead to a new problem, which is creating a mutation in the beta globin gene that makes a person anemic with a need for transfusions? And then does it work? Are there enough edited cells to stop pain and other sickle-related problems? And if there's a benefit, is it long lasting? I predict that it would be, because we've eliminated the sickle mutation, which is the cause of the problem. But we have to show that. So those are the things we are hoping to answer in this initial clinical trial. But we're not finished. This is really just, I think, the start of the the field, because what we really need is what I call an ideal cell therapy. And this is what I think it would look like. It would protect from sickle related complications, both those you can see and those you can't see, with acceptable short-term and long-term side effects. It would be accessible and available to most patients, not just in the US, but worldwide. And it would be equally safe in children and adults. And when compared with the standard treatment, there would be a benefit of this as a curative therapy. So, so I think you would agree we are definitely not there yet, but this is a worthy goal, and it's events like these that we hope to generate excitement and continue this important work. So I think the question for my particular trial is there a risk of leukemia or cancer with and then in general, what is the long-term outcome after decades? We don't know. Will the cost and complexity of these treatments restrict access to care? Well, they almost certainly will. And the question is, can we convert this from being a limited available treatment to one that's broadly available? And then the question I always ask, do we have an approved ideal cell therapy for sickle cell disease? I don't believe we do, which is why it's so discouraging to see these companies drop out when we need them to help us develop better and better tools for treatment. And then my last slide is just to acknowledge the funding I've had to do the clinical trial that I'm working on, both from California Institute for Regenerative Medicine and the Cure Sickle Cell Initiative at National Heart, Lung, and Blood Institute at the NIH. Thanks very much for your attention.
Wonderful. Thank you so much, Dr. Walters, for a very thorough presentation. I know it can be hard to include so many details in such a short amount of time. And so I really hope that folks feel like they got a good overview of what the gene therapy treatment process can look like, what are some of the risks and benefits, and also really understanding the landscape and what options are still available. We have some great questions in the chat that we'll get to at the end of our session. Don't worry, we will get to the questions. But before we get to the questions, we'll have a patient and a caregiver. And yes, it's great to know the science, to know what you're walking into, but there's something different about hearing someone's experience, having gone through gene therapy, and also having been a caregiver. And so today we have Glory and Rebecca Emanuel. They are a brother and sister duo. My brother was my donor. And even though Glory did gene therapy, I love to see a sibling duo tackling life together. And so I can't wait to turn the floor over to them. Glory is wow, like meeting him is like getting a breath of fresh air. He's very excited and invigorated to advocate for warriors and to make options like gene therapy available more broadly. And even after doing such a rigorous treatment like gene therapy, he is already back on the move, volunteering with sickle cell camps, and he launched his own nonprofit called Rare Hope Foundation. And his sister, Becky, has just been by his side this whole time, and she really has a lot of great input to give. I think sometimes I've heard this. I literally just heard this yesterday. Someone was like, "Oh, I'm a nobody. I'm just a caregiver." And it's like, no, 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 absolutely not. You are so pivotal in the warrior journey. And so we hope that after having a very educational session with Dr. Walters, you can hear the lived experience of a warrior and his caregiver. So if you guys can come on video, I know, Gloria, you've had some issues logging or showing yourself on camera and also having good audio. So I will um, change it to look like this. Actually, I don't know if I want to do that. I'm going to go back to hiding uh, not video participants. Glory, if you want to try to turn your camera on and talk, that would be great. But if not, if we're having trouble hearing you, we can go ahead and turn off your camera. But we know nonetheless, your story will be really impactful. So without further ado, I'm going to turn it over.
Thank you so much, Christelle. Can you guys hear me all right? Awesome.
We can hear you. This is great.
Yeah, so I can start off with maybe how my health was with living with sickle cell. That works.
Yeah, that sure does.
Perfect. Yeah, so I think the first time the first crisis I can remember happened to me when I was, in elementary school. So I went to school in Nigeria, and we have one of the largest populations of people, living with sickle cell disease. But having this crisis, when I was there, the only thing that would really be offered to me, as far as treatment was, an IV fluid infusion. So yeah, at times I would just spend days in pain, till, the whole thing subsided. And it wasn't until I came here to the US, for my college that I, had my first glimmer of hope when I had a crisis and was taken to the emergency room and was able to give something for my pain. So since then, at that point, I thought even though I have this situation, at least whenever it gets that bad, I just go to the hospital, spend a few hours in the ER, and then help the pain subside, and I'm able to resume, back to regular programming. This is what I was doing for the 4 years of college, and it worked for me all right up until, my situation turned for the worse when I started working full time. So I was working in a pretty demanding role, and wasn't really used to the stress that was involved with day to day, working hours at a time. So I started having, frequent and much more severe crises when I was in my professional career. Sometimes I would be in hospital for like 3 weeks at a time, and it started affecting like my day to day and professional life. So I would end up in the hospital about like once every 2 months, and then it wasn't really till during one of my hospitalizations, I had an MRI that revealed that I had a bone infarct, that I knew I couldn't just manage symptoms any longer. And I wanted to find something that could put, a stop to the complications that arise from the disease. And that's why I started looking for curative solutions before I have something, much more severe like an acute chest syndrome or a stroke. So that's really what led me to this few years journey into gene therapy. Um,
Awesome. And thank you for sharing that context and also giving us just the capacity to understand what the warrior experience is like globally. Not having even access to fluids. And I just think giving people an understanding that warriors struggle everywhere, but everyone's journey to gene therapy is unique, and what brings us there can be different. And a lot of the times it takes something really severe happening to really like, okay, things have to look different. Hopefully that's not the landscape forever in gene therapy, but or even transformative therapy in general. But yeah, thanks for sharing that. And I wanted to give Becky a chance if you wanted to add in, like, what was your thought process being a sister, watching him go through all that he went through as a kid and then growing up? And were there things that you were concerned about in terms of gene therapy and his decision-making process?
Just to comment a little bit about him. Can you hear me all right?
Yes.
About him, what life was before I was his sister. I didn't really know much about what he was going through or his pain in the early years of his life, mainly because our parents kind of dealt with it. And because of that, the first time I actually understood the extent of pain he was having was in college when he did have to go to the emergency room. I remember explaining that I felt a little bit of guilt because one night he called me like 2 a.m. like, I'm feeling pain. I was like, okay, call the campus safety. I might be a little far. And then they just had to call the ambulance for him. And then I was like, oh, this is serious. So I got to the hospital, and then I realized, oh, this is really painful for him. And I watched him in pain. That's when I really understood just how he might have felt. But before then, I don't know if it's because he was much younger, or maybe it wasn't as excruciating as it was when he got to college. I didn't really know too much. I just knew that he was a little fragile his back had to be protected. So I knew that much. So it's kind of interesting hearing some details that he's sharing that I actually didn't know about. In terms of the gene therapy, I just knew from after college watching him go to the hospital and how much more often he had to go to the hospital that this was not sustainable. So we knew something had to be done. I thought we were probably going to do a bone marrow transplant because that's tried and true. So when he brought up this gene therapy, I was skeptical. Uh, it took a lot of talking to Dr. Walters and Marcy over and over and over and looking over the documents and talking with my parents and explaining it to my family in a way that would calm the anxiety. So yeah, it took a lot of time just to understand what this would look like, what opportunity this would provide for him, whether it would help him feel better, whether it was in fact a good decision to make. Um, but because they took time with us to go over everything, answer all our questions, I did not lack on the questions. I had a lot of questions and I was sending them to Marcy. Like I had lines, I went over contracts, everything. I think I felt a little bit more safe and obviously I knew I had to be there so I can also know that everything went well. So yeah.
That's a good sister right there. Good sister. And yeah, I think that you highlighted so many good points. Um, Things are scary and there are hesitations, and it's not about running away from them, but how do we address them head on and just sometimes it's hard. You don't know what you don't know. And so like how do you even know what to ask? But I think it's so good that the things you were concerned about, you were like, hey, I need clarity on this so that I can feel confident in the decision that I'm making, knowing that not everything might go the way I want it to, or it's not going to be perfect, but that I at least feel like I'm making a decision where I know what I'm walking into, whether it's certain or uncertain. And so we have maybe like 10 more minutes. I wanted to, there are so many things I would love for you to share on. I think if you could summarize with us, Glory and Becky, can you tell us what were the specific things you were hesitant about when it came to making a decision about pursuing gene therapy, and then being on a trial versus standard of care, like getting one of the FDA approved ones? And then Glory, if you could give us some more details. I know people are already asking in the chat, like what was your personal experience like? What was it like going through each phase of gene therapy, pre-transplant when you're preparing, while you're in the hospital, and then now that you are, I think, what, 3 months out? Is it, no, more than that.
About 4 months.
Or, wow, yes. So yeah, if you could share, if you could answer those two questions, that would be great.
Yeah, no problem. So when I was trying to make a decision on which gene therapy to go through, I had the option between the Ruby trial, which, as Dr. Ross just mentioned, was recently discontinued. This used CRISPR-Cas12a to edit my cells to produce fetal hemoglobin. And then there was another trial that used the lentiviral vector technique. I chose Ruby because I felt it was a more precise and targeted form of treatment as far as that gene editing process goes. So that's why I made that decision for that trial. And yeah, I definitely, had a lot of barriers when I was trying to go through the process. I had to stop at some point. Before even the, Ruby trial, I was looking at other trials that also ended up stopping recruitment. So there were a lot of like hurdles like that, when finding one that would be approved for referral, for me as a patient that was, good and still recruiting. And then I also had a hard time like explaining to my parents why, my whole family why I wanted to do this. In their head, they're like, why should I want to take this risk instead of just continuing to manage my symptoms? Especially since there were, other things like hydroxyurea and stuff like that that I could try to use to, have a better quality of life. For me, it was just knowing that I wanted a long and fulfilling life. like the slides Dr. Walters showed, the life expectancy for someone suffering with that is not very high. It's significantly lower than, people that don't have the condition. So I wanted to be able to be there for the people I love, and that was the biggest driving factor in, deciding to go through with it. And like Becky mentioned, the UCSF team came in and they were incredible with just taking call after call to explain, all our questions, to explain the process, answer all my questions, all my parents' questions, and that's why we felt really comfortable to be able to go through with this, with UCSF. Um, as far as the process for the, treatment itself, the exchange transfusions alone had already like really increased my health. During the period I was getting exchange transfusions, my pain crisis was, almost non-existent. And even though I had access issues with the veins, and sometimes I would have to like get admitted beforehand so I can get a catheter placed to have that transfusion, it was a mostly seamless process. I also had to have the stem cell procedure done twice to be able to harvest enough cells for the procedure. And recovery for that was also smooth as well. My actual hospitalization for the transplant took about like 2 months in total, from the final exchange transfusion to my conditioning, to the transplant date and finally discharge. It was about 2 months, and I had a pleasant stay. The nursing staff made it very comfortable. And I was able to still do a lot of my day-to-day care routine, pretty normally. So I wasn't like fully bedridden, but it was still, a pretty serious procedure. Dr. Walters mentioned, the mouth sores that happens as part of chemo. That was, one of the probably most painful, one of the most painful side effects for the chemotherapy, definitely. And also the other part that's more, mentally tasking, I think, is the fact that you do have to live with the with the side effects like the infertility. Thankfully, the trial I went with did make prior arrangements for that, so I did have some, family plan arrangements made, and that put my mind at ease for that side effects as well. Yeah, as far as recovery went, it was, slow at first once I got discharged. I had some hard times falling asleep, and staying asleep. I had appetite loss, a lot of things that was mentioned, already on the slides. But as time went on, I've already dropped a lot of those like side effects. I feel much better, much more myself. Gained a lot of weight. My hair is coming back. Doing much, much better. Yeah, so that's just how recovery was. And I'm now 4 months post-transplant. And I'm still surprised how much has changed, in just a short period of time. Yeah. I haven't had, while not having to receive, any blood transfusions, I haven't had any pain crisis since my transplant date. And yeah, I'm doing much, much better.
Wow, that's like so heartwarming. That's so beautiful to hear. And I can see, like I see your hair. Like I saw you like a month ago, and I'm like, wait, there's so much hair there now. Oh man, thank you for sharing that with us and just walking us through a little bit of the journey. And it's so interesting because as I'm hearing your story, I'm thinking about things that are like I'm thinking about my own process, even though I got a transplant, I did not get gene therapy. But just thinking about like, oh yeah, like it's interesting that you thought exchange transfusions were like you felt a lot better because I actually felt pretty crummy during some of those exchange transfusions. But the end goal is still the same, that we could have a different life, have a chance at a new kind of life. And to see you on the other side of that, he's at camp volunteering, guys. Like I'm just really happy to see the transformation. I can see you physically looking so much better, and it wasn't a perfect journey, but I'm just so happy to see you doing well. And I know I'm rambling a lot, so I wanted to pause and ask Becky if you wanted to add anything um, that to give us context from the caregiver side.
Um, Trying to think of exactly which part to share. There's a lot to share, but I think for me, it was, when I was describing the decision making, it felt like I was making the decision for myself. But obviously, I was not feeling the pain. I only witnessed it. It looked horrible. And so I took it personally just because I'd seen what he's been through. But then to imagine watching him when he's going through it, like even having the mouth sores and him being in pain. I know my brother is very strong. He handles a lot of really intense pain. And when he was having some of the mucositis with the sores in his mouth, I think there was like one time where he cried and there was nothing I could do. It was terrible. It was terrible. But all you could just do is just be there, and just show up, try to talk about other insignificant things in life. Makes it seem normal. But to say I am proud of him is an understatement. Just first doing the research, staying true with us, even when we were giving him a little bit of a hard time to um, get the ball rolling, really. And then even when some things weren't easy in the process, just following through. Um, it also gave me strength to just stay beside him and continue to um, show up every day at the hospital, get on his nerves, because that happened a lot. Unfortunately, there's no way around it. Apart from the fact that we're siblings and we will get on each other's nerves, we got on each other's nerves to another degree. But I wouldn't change that process. Um, it's 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 amazing to think about what it was in May and what it is now. You know, he talked about him gaining weight. He's never looked like that. He's never gained weight to that level before. And I think it's a good thing because I feel like sometimes, depending on each sickle cell warrior, they have different things that maybe they can't achieve because of it. But I think from when he was young, he's been very skinny. So it's been nice to kind of see that change. And I took it as a positive thing. One thing that was funny is we really thought he wasn't going to lose his hair, because we were just like, Nigerian hair does not come, it's tough, And I remember when he would tie down his scarf and Marcy was just looking like, okay, you keep tying that scarf. Eventually we're going to have to check. And we were like, it's not going to happen. Like, the chemo won't do this. And then when he had to take it off and the whole thing was gone, I was like, no way. So that was one funny thing, though it's now funny because his hair is growing back. But yeah, it's been positive changes. I was nervous at first when he came home, but then so proud of him. He's going to the gym now. He's going outside. His appetite is picked up. I wish he would stop eating so many sweet things, but he's eating. Yeah, and you can clearly see he's very passionate about helping other people have access to this, know about this, and show them what life could be. So I'm so proud of him and just so happy to have witnessed that. I think one thing I would say to caregivers is definitely lean in. Know that you can't give what you don't have. So I think it's important to take care of yourself. There were some times where I felt a little bit of guilt sometimes. Thankfully, I had my mom come join me when it was hard. So grateful to her. Well, also she was bugging me too because she wanted to just be there. So I couldn't stop her. But it was really great having her. And that gave me some time to rejuvenate and refresh and then come back again. So I would say you definitely need to take care of yourself so that you can take care of your loved one. Yeah.
So good. That is awesome, Becky. I'm so glad you mentioned that, because I think caregivers often give, but it takes a village and you have to refuel. We're a few minutes over, but I did want to ask you, Glory, one last question. Just like Becky just gave us a final like word of advice. What's one piece of advice you would give to warriors who are interested in embarking on this journey or are already embarking on it? What's one piece of advice you would share with the warrior community or even the medical community in general? What's something that you feel is really important to share?
I think definitely this journey is a personal one for each and every one of you. I want you guys to do your research. have those meetings with the doctor. I think they will always be available to you. You know, they care about your well-being too. So have those meetings, do the research, determine which course of action is best for you. Bring your family along, you know, throughout the whole process, you know, have them heavily involved. And when you are able to go through this, when you come out on the other side, don't forget to, you know, pull others up as you're climbing. You know, like I, I, I always say, you know, I'll always be a sickle cell warrior, even though now I'm living life, you know, without pain and worrying about those things. I just want to make this type of, you know, what make the blessing I got available to other people. So that's why I strongly believe in gene therapy. I strongly do think it's the future, and I want to make it more accessible to those that need it. And yeah, just and don't forget to give yourself some grace as you're going along too. It is a hard process. It can take a lot out of you. You will notice yourself change in a lot of different ways. But you know, you are still you, and you know, things will get better. So that's my request.
Oh, well said. I have nothing else to add. And with that, let's transition to our Q&A session. Dr. Walters and Marcy, you could go ahead and yes, even you, Becky, I know you're actually logging off, actually, but thank you for joining us. Yes, turn on your cameras. We have so many good questions in the Q&A box. I did want to mention that we will be putting a survey in the chat. And you can just let us know what you think. The reason why we have this survey is so that we can get feedback. We don't want to host these events just for us. The events are for you, for the community. And so we want to hear from you what you find helpful, what you would want us to touch on. If there are things we missed, if there are opportunities for improvement, please let us know. But we still have 15 more minutes, and we will use every last minute for the Q&A session. So I'm just going to go ahead. Oh, and you're getting thank yous in the chat. Glory, many positive comments. Dr. Walters, can't wait to meet you. Hanif says thank you. So lots of thank yous in the chat. Glory, thank you so much for being vulnerable and sharing your experience with us. So we have 14 questions. I'm going to go down the list. And if there's time at the end, I don't think there will be, but if there's time at the end, people can raise their hands. But if you have a question in the meantime, please just put it in the Q&A box so that everyone can see. And what we don't get to, we'll make sure we get answered and distributed via social media. Okay, so the first question is gene therapy available to and advisable for older warriors 40 years and up? If yes, does it pose any higher risks?
Yeah, what's interesting about, for example, the Life Genia label. So this is the information that the drug has, as approved by FDA, has no life span limitations. There's no age limit. So yeah, as a 40-year-old can receive one of these treatments, but whether it's the right thing to do or not it depends on how healthy you are. So one of the things we do for everyone is we spend at least 2 weeks looking at vital organs and general health, and we get a better feeling for whether or not it's advisable to go ahead. And your doctor will tell you if they find something that it wouldn't be safe to do. So the only way to answer that question is to get evaluated. But in general, no, that age of being 40 is not an exclusion.
Great. Anyone else want to chime in before I move on? Okay, and actually, while we're on the topic of age, there is a question in the chat, not the Q&A box, but have there been discussions for gene therapy for children under 12?
Yes, there have been, and there are trials that are just being finished that involve children less than 12 years of age. So I think that will eventually happen. It's interesting. The reason why they weren't included was because of this risk of leukemia. But um, in my opinion, the risk of leukemia is lowest in the younger patients. So it's funny how FDA thought that this would be a safety approach. I'm not sure I agree with it. So I think it's just a matter of time before we start to include younger children.
Awesome. Great for that. Thank you for that answer. Um, wow, there are some age questions. I think while we're on the topic of age, I'll just stick to those questions. There are two questions that are slightly related. One question says, I am 54 with sickle cell beta thalassemia. Would I qualify? Um, and I think you just answered this, but just to confirm, is there a target recommended age range by which gene therapy would have the greatest chance of success? Like, for example, is gene therapy available under 10 years old? Is that a more ideal time than getting it in a different time frame?
Yeah, I think 12 to 35 years of age is probably the ideal window. A 54-year-old, you can imagine that the blood system has been around a while. It's taken a lot of toll. It's very inflamed part of the body, the bone marrow, and just getting enough healthy stem cells collected could be quite challenging. So, but again, I think there are some 54-year-old warriors who are in really good shape, and it might be something that's feasible to do, but I would worry about it. Yeah. And I'm a pediatrician, so it's easy for me to say, "Oh, sure, let's do it." But I wouldn't be actually taking care of you. So it's really up to the adult physicians, the adult team. And the other thing that's been happening is that I think, more pediatric uh, sickle cell centers than there are adult centers who are carrying out this treatment. So there's that access problem, which I think is by and large the biggest challenge. Um, it's just finding a place where you can get the treatment.
Yeah, that is definitely a fair point, and I'm grateful that I was able to get mine at a pediatric institution, even though I was considered a grandma in the peds world.
A
Look at these cute kids. Okay,
young grandma.
a young, very, very young grandma. Very young grandma. Okay, I'm going to try to speed through these questions. Keith asked, what is the medication protocol post-transplant? If there is one, what are potential issues if a person is non-compliant?
Yeah, that's a great question. So after a gene therapy treatment, most of the medications are to prevent infection. So if you're not taking your medicines to prevent infection, then you could get a serious infection. So, but there aren't any medicines to suppress the immune system or to treat a particular complication. Some of our warriors were still taking their pain medication, and you know what happens if you miss your pain medicine. You can have pain or withdrawal, so that's a bad idea. But yeah, not a lot of medications, and it's hopefully easier to remember because there are fewer of them.
Great. Okay, I'm gonna mark that as done. That was a great question. Um, can participants be set this presentation? Oh,
Sure.
we will, okay, perfect. Thank you. We'll send the slides, and then this session is also being recorded, and we'll make that available for everyone. Next question. My understanding of chemotherapy for cancer patients is that the patients receive one of four drugs that they can get in combination for their treatment. Hair loss happens in patients who receive more drugs on the chemo combo. Does that mean it takes several drugs to correct/modify our genes as well?
Yeah, that's an interesting question. So for the gene therapy, we just use one chemotherapy medicine. And the reason why is that the only objective is to create a space in the bone marrow for the modified cells to grow. And so we got to clear out a space, and we want to eliminate the sickle producing cells. In a bone marrow transplant where we're using a brother or a sister, an unrelated donor, we got to do two things. We got to create space, but then we also need to suppress the immune system so the donor cells aren't rejected by a person's immune system. So that's why we add the extra two or three drugs.
And then I will just add, even though it's just one chemotherapy and gene therapy, it is one of the strongest ones that we use. So the toxicities of hair loss and all of that stuff still go with that, even with just the one.
Okay. Yeah, I think that's great that you answered this question because I think the goal of chemo and cancer versus transplant for sickle cell are different. And so thanks for clarifying that. I am going to keep the train moving. So if considering gene therapy, what would be the specific first and subsequent steps to start the process, including insurance coverage?
Yeah, I'll let
Yeah.
Marcy go through that.
Yeah, I can tackle that. So one of my most important roles in my job is that I act as kind of the bridge between Dr. Walters and the clinical team and the patient. And so we also have two other nurses in our clinical program who do that same role. So the first step is getting to us, and most of the time that takes a medical referral from the primary hematologist. Even if a patient reaches out directly, we will do our best to get them in and seen and have the initial educational consult to see if these treatments are right for them. But the medical referral really helps to facilitate that because most of the time the insurance requires that in order to provide the authorization for a consult and treatment. So that's really the best way is to work with your primary hematologist to reach out to us and give a summary of your history and complications that you've had, previous treatments that you've had, and it really gives a justification of why this type of treatment would be something that would be in your best interest or something to consider. And then that just helps the process smoother. Then it does take several weeks to sometimes several months, depending on what type of insurance plan that you have, to get that authorization in place. But we have a skilled team here that has a lot of experience. So I'm confident that we can tackle any obstacles with that. And then getting in to be seen and start the discussion. Once you're kind of in the pipeline and meeting with us, the cadence and how quickly things move really depends on what works best for you. So sometimes we meet with patients, 2 or 3 times very close together because they've already done extensive research on their own and they come with different questions and a different level of being ready. And then other patients we meet with several times over many, many years, just depending on if they want just updates, but they're not quite ready to move forward. So that type of cadence and decision making is really patient specific.
That is a great summary. Thank you, Marcy. And I will just say also, there were in my process of trying to get transplant at the Sickle Cell Center of Excellence at UCSF, I spent months, if not years, trying to get certain things covered and taken care of through prior auths at other institutions that were just handled a lot more smoothly up here. Not to say you shouldn't get your care anywhere else, but I will say that they know what they're doing here. So just a little plug. Um, and just practical help for warriors because I know we're already going through all the hoops. And so if you can be helped going through the hoops, I know I appreciate it. Um, we have 3 minutes left and many questions. I was wondering if our panelists would mind staying on for an extra 10 minutes. And folks who want to log off are welcome to. I want to honor everyone's time, but I think that it would be very sad if we left this many questions unanswered. And if I could ask Shelby or Abigail to take pictures of all the questions that are in the chat just so that we can answer them. We answered 11, but there's 18 left. So I want to get through at least a few more before we close out. Is that all right with you, Dr. Walters and Marcy?
Yes, of course.
Yes.
Okay. I see Les has asked this question a couple times. I think it's a great question about when trials will be held for patients with beta thalassemia, and that feeling of being overlooked. And I know the same thing with hemoglobin SC. She's mentioned that she was admitted twice this year, and she doesn't qualify for any of the trials, and was kicked off of one because she didn't have SC or SS. Um, What about us suffering just as badly as someone with SC or SS? It's unfair how we are demoted to not being taken seriously as other types, even though we literally go through the same kind of hell, just like any other sickle cell patient.
Yeah, I can understand that feeling. It does feel like you're being ignored. In our particular trial, one of the side effects of the gene editing is that we, more often than the correction, which is the goal that we're trying to achieve, create a thalassemia gene. So if you already have a thalassemia trait gene, and then we create more, it just wouldn't be safe to have you in the trial. So for us, it's a safety issue. It's not that we're ignoring you. It's just that we don't want to make your disease worse. But Casgevy has included patients with sickle beta thalassemia, and so that would certainly be available to you. It was equally beneficial in NSS and S beta thalassemia, and I can't think of a reason why Lyfgenia wouldn't work too. So even though you may not be eligible for a trial, you can certainly be eligible to get one of the approved treatments.
That is a great call out. Thank you for that. I'm gonna go ahead and keep it going. Oh, someone asked, how do we have a consultation with you?
Well, that's easy. Christelle knows the answer to that.
Yeah, I mean, we have, so the great thing is Shelby has put it in the chat a little bit earlier. Maybe if Shelby, if you could put it in the link again, we have our link tree, which will connect you with the resources that we post online via social media, and the collaborations we have with other CBOs. And then there's also a survey that is in that link tree, and you can use that survey to get more information about the CRISPR SCD trial, and that also will prompt you if you would like to be contacted. You can put your contact information and you can get connected to Marcy, who is, like she said, the bridge. And so for those of you who are really interested in considering being seen by our team, you're welcome to use the link tree and the survey in order to be connected to us. If for some reason after the call you don't click the link or something happens, you can DM me on Instagram, UCSF Sickle Cell, and um, I'll be sure to relay your contact information. And again, and the survey that we have also being circulated in the chat, you can leave your contact information if you would like to be contacted by us. And so you can also put your contact information in any comments there.
And I know I
In
mentioned
our,
the
Go
medical
ahead.
referral, but I'm happy to talk with anybody who's interested in learning more or starting the process before you even have the medical referral from your primary too. So don't let that be the limiting factor to reaching out.
And we will cover all of your options, not just participation in my clinical trial. Because if I think you would be better off doing something else, I will do that after I get a chance to evaluate you and look at your medical record.
And I will say, don't know if I don't, I don't know if I'm allowed to say this, but this is just my personal experience. When I was considering different transplant options, I didn't have, had just gotten access to a sickle cell specialist. There were a lot of things in my medical care that I was lacking. And so I happened to reach out to Dr. Walters through a mutual connection, and like by the goodness of his heart, he took the time to meet with me. So I just, where there's a will, there's a way. Don't feel like you can't, like there has to be this specific way. Of course, we love a referral and all these things, but just really reach out to us. We want to help. Dr. Walters wants to help. Marcy wants to help. They're nodding their heads. So yeah, just reach out and we'll help you in the way that we best can. Um, okay. Hanif has a great question. I'm keeping an eye on time. I think we have like, if I'm doing math correctly, 7 more minutes. Would there be potential benefits of using reduced intensity conditioning and replacement for um, myeloablative conditioning for some gene therapy clinical trials, especially considering that it's autologous? Um, while there are present consequences, is this trade-off something of clinical interest for authorized centers? And he's asking primarily because Casgevy and Lyfgenia both include myeloablative conditioning regimens at this point, to our understanding.
Yeah, so that then becomes a clinical trial question, right? And the reason why we're nervous about that is the myeloablation means complete. So the intent is to completely eliminate any blood stem cell that isn't making the modified hemoglobin or the fetal hemoglobin. And if you give a reduced treatment, that means it's incomplete. So you will be mixing in or diluting the treatment effect of those modified cells. So unless you're modifying 100% of the stem cells, and none of these treatments do, it might be 70%, it might be 60%, it might be 80%. You can imagine diluting that in half and then hoping, praying that it still had the same transformative effect. And I worry that it wouldn't. So that's in a nutshell why we're not going there off-label, that is outside a clinical trial. And it's something that would have to be, in my opinion, studied carefully in a clinical trial.
Great question and great answer. Thank you so much. So we have Andres who asks, he says, thank you so much, Dr. Walters, for a great presentation. Could you describe how you plan to monitor the risk of leukemia on the CRISPR-SED trial? Have companies that dropped out been due to data related to leukemia risk or lack of profitability given the prohibitive costs? Wonder if those reasonings are disclosed.
So the way it's imperfect how we monitor and screen for leukemia, but we get a bone marrow test before enrollment, and then we check it again every 6 months for the first 2 years. And what we're looking for are acquired changes, presumably from the treatment, that would increase the risk of developing leukemia. So there are cancer-causing genes that you can screen for using, DNA sequencing techniques that have a very high sensitivity. That is, you can detect just a few of these changes that might indicate that a person's on the path to developing leukemia. So we do that monitoring throughout the trial, and then we do that monitoring at least through 5 years after the treatment until we're convinced that that hasn't happened. So, but that's not really a reason for not pursuing commercialization of a promising product like Ruby. I strongly suspect, and this is what they've told me, so I think it's true, is that they just didn't have the resources, the money, if you will, to do it. It's really expensive to get a product ready for commercial use, and then we've seen the experience with the current approved treatments and how slow it has been to ramp up to get a large number of persons treated. So the way they make profits is they treat lots and lots of patients, and that's just been really hard to do. So the marketplace has made a decision. It's not about safety.
Mm. Okay, thanks for that thorough answer and the context in which why some of these decisions are made. I am going to mark that as done. We have 3 minutes remaining of our 10 extra minutes, and there's still so many questions. So I think I'm trying to see what are some of the things I think we haven't touched on.
One question here is in terms
Yeah,
of long-term fertility, is
yeah,
there
I was just about to tell you that one.
yeah, so it's about the same, males and females, long-term infertility. So we used to think that maybe males it was less so, but as we get more experience, I don't think it's different. I think it's still a near complete outcome of the treatment.
And then I think one more topic, thanks for touching on that. I'm just trying to like cherry pick to see what we haven't touched on at all. Someone asked if gene therapy would ever be able to be done in African countries and how, like, what would it look like to bring an initiative to countries with in different regions of the world?
I've thought about that for years, and I, I can count out the number of red blood cell and platelet transfusions you need to give after a sibling bone marrow transplant, and there's not very many. And if you could line up some donors and do the treatment with in a modified way, and if families are very large the way they are in some families in Africa, it seems like that would be feasible to do, but it just isn't. Still expensive. Um, it's like Gloria was telling us, he couldn't even get fluids when he was in terrible pain. Um, so it's just not going to be a solution. The the thing we dream about is in vivo, that is just injecting some medicines and having them correct the sickle mutation without having to go to the hospital overnight, without needing chemotherapy. That might be something that we could do in places that have limited resources. So that's what we dream about. But even that, I worry, will still be expensive.
Mm. Thanks for that. I will close out our session here since we are a minute from the end of my 10-minute extension. Thank you for those who stayed on. Um, oh, wow. Dr. Adeshina just asked a really good question. And so what we can do, she asked, would in vivo gene therapy mitigate risk for infertility if we're
Yeah, it would. Yeah.
conditioning regimen? Um, so the quick answer is yes. What we can do is, again, capture the rest of the open questions that have not yet been answered. And we will go ahead and make sure that we can get those questions answered and made available to the attendees via social media, maybe a reel. I haven't figured out exactly how we're going to do that, but we'll make sure. Oh, they've been captured and we'll make sure they get answered. Thank you for staying on past time and for joining us and contributing to a really rich conversation. These questions are awesome because sometimes you need multiple people together asking questions together for us to push the envelope. And so I really am grateful for those of you who spent the time with us this morning. We hope that you found it valuable. And this will definitely it's not the first and it won't be the last. So thank you so much for joining us. Any last words from any of the panelists still on before I close us out?
No,
I'll just
thank you.
I'll just say I'm proud of all of you. You had incredible inspiration, Glory, Christelle, and all of the warriors on the town hall. So
Yeah,
thank
I
you.
didn't get a chance to comment on Glory's journey, but it was sensational. So I couldn't be more pleased. I think of the things in my work life that bring me joy, and watching you today, Glory, brings me great joy.
Thanks
And
so much.
Christelle, always.
So much
Thank you.
joy. And thank you. I also want to just add a quick thank you for the people on the back end who you can't see on camera. Abigail, Shelby, Christina, there are so many people on the team to make this come to pass. Marcy is like, I feel bad for her. I'm like, hey, can you help us with this one more thing? She's always available. So thanks for joining us. It's a team effort, and we hope to see you all again soon. All right, take care.
Bye.
Bye.
Thank you.